Just give it one more minute and then we'll start. While we're waiting for everyone to trickle in, please remember to use the hashtag ePrescribing Masterclass and tag us if you're going to put this on social media. Okay. Okay. Still waiting for people to trickle in. Okay, so I think I'm really going to start the masterclass now. So welcome everyone, and thank you for giving up your time and joining us today at the ePrescribing Masterclass. I just want to say thank you to all those who attended the last session that we had, which was a mixed joint session between the Medicine Safety Officer Network and the ePrescribing Network. We're hopefully going to have a repeat of that session and try to make them every 6 months and do them biannually. So the next one of that session, type of session, will be in September. But today we've got a packed agenda. We've got 2 different hospital trusts and 2 different informatics teams come to present about their implementation and how they have solved an issue. So I'm going to hand over to our next speaker, which is Ampreet Sidhu, who from Barts Health NHS Trust, who's the lead informatics pharmacist at Barts Health, and she's been in that role since 2018. So she's going to come and talk about the implementation of the EPMA system across 4 major hospital sites during the pandemic. So I'll hand over to you, Ampreet.
Hi Stephanie, thank you very much. Thank you for the introduction. So as Stephanie said, my name is Ampreet Sidhu. I am the lead pharmacist for informatics, and I'm just going to run through the implementation of EPMA at Barts Health. Next slide, please. So I'm just going to quickly run through exactly what was included within the scope and what was outside of scope. So all 4 sites were within scope, so that included the Royal London Hospital, Whipps Cross, Newham and St Bartholomew's Hospital. We included all adult inpatient areas, including critical care and the emergency departments. We did actually exclude outpatients, day cases, paediatrics and maternity wards. Within our scope, we looked at the routine and complex medications, which included medications such as variable rate intravenous insulin infusions, looking at oxygen. All drug histories are recorded within the system, and inpatient prescribing. We also had the ability for independent prescribers and PGD prescribing. So PGD prescribing included TTAs as well as one-stop as well as one-off. We also tried to improve the discharge prescribing, so to improve the information that we are sending to our primary care colleagues, so that was also included within the scope. Part of the exclusion criteria was parenteral chemotherapy, so they currently use a system called ARIA, so we kept that in place. And we didn't the system in any way to include insulin pumps, so we had something called a placeholder, so we didn't build anything into the system. Next slide, please. So you're looking at the EPMA rollout. We started off at the Royal London on the 28th of August. The Royal London is approximately 700 beds, and we started off with clinical documentation, which rolled out on the Saturday, the weekend before. So that was getting all the doctors to start documenting everything electronically. The nurses at this point were already electronically recording observations, so that was a system that they were already quite familiar with. And then electronic prescribing of medicines and administration went live on Monday the 30th of August, which was actually a bank holiday. It was actually quite good to go on the bank holiday because it wasn't overly busy on that day. We were actually quite lucky. We didn't have a huge turnover of patients. We managed to engage extra staff to come and help us during that time as well, so it actually worked out really well doing it on the bank holiday. We managed to flip 6 wards on that first day from paper prescribing to the electronic prescribing. So we considered that quite a successful first day. Initially, we had actually planned to be at the Royal London for approximately 3 weeks, but I think we felt that we had to support them a lot more than we initially had anticipated, because it was the first site, it was very large, and we did have some teething issues. So we ended up staying there for 4 weeks. So that was all of the EPMA team, as well as all of the informatics teams as well, which then pushed our rollout to Whipps Cross by a week. So Whipps Cross was then rolled out across 3 weeks. Whipps Cross is a district general hospital with approximately 470 to 500 beds. So it does have a big bed base of care of the elderly patients, and again has an intensive care wards as well, so it did have its own challenges. We then moved on to Newham Hospital, which we managed to roll out in 2.5 days. Newham is a district general with approximately 250 beds. We supported them for 3 weeks, so we were there for a period before the rollout and for post rollout as well, to make sure that we were able to provide on-ward support. So that included following drug rounds, supporting for drug histories, and making sure that people were feeling familiar and confident with the system. Finally, we went to SBH on the 22nd of November. So SBH has approximately 250 beds. We rolled out over a course of 3 weeks. The difference with SBH is that it's a specialist tertiary centre. However, it doesn't have an accident emergency. So although it did present its own challenges, because it does have 10 cardiac catheter labs, which were initially not in scope. However, we found that if the patient was coming from an electronic based drug chart going to cath labs and then going back to the electronic chart, there was a risk that medicines could be missed. So we then had to include them into scope. So we then, during the rollout period, just before we went live, we managed to facilitate the rollout of the cardiac catheter labs as well, which actually went really successfully. Next slide, please. So we started off at the Royal London, and I think this was definitely the right thing to do, because the Royal London is our largest site. We've also got, it's also a tertiary referral centre. We have a lot of specialists and high acuity patients. We also have a bed base of approximately 44 ITU beds. And during this rollout period, we were able to have Cerner on site with us during this first 2 weeks of us being at the Royal London. So if we had any issues, they were there on site to help and support us. And so we managed to iron out a lot of the issues that we then didn't face going forward at the other sites. So I would recommend having the support of your technical team if you can at your biggest site or your first site if you have multiple sites. So in terms of the order of the rollout of the wards, we tracked the patient's journey back. So we tried to go to our long stay wards first. So for example, care of the elderly wards, and we went to long stay surgical wards and then tracked the journey back to the emergency departments. We did have patients going from EPMA to non-EPMA areas, and the other way around, from non-EPMA areas going to the EPMA areas. So we tracked those patients on a daily basis, and then we mocked those patients up. And then, so if we had to transcribe the chart to an electronic chart. We were doing that on a daily basis using members of our transcribing team. So the paper drug charts had to be transcribed to the electronic system. We had a dedicated team to be able to do this, which included clinicians and pharmacists. I've got a slide on that next, so I'll talk about that separately. We successfully managed to roll out electronic prescribing across the whole trust by the end of December 2021. So next slide, please. So the go live preparation. So we started off with having a user acceptance testing. So this basically included asking members of the MDT, so we asked doctors, nurses, pharmacists, and dietitians to come in and test the system to make sure they were able to follow the patient journey from admission to discharge. Different people were looking at different sections. So dietitians were looking at the PN, looking at making sure that they were able to prescribe it, were able to administer it. This was actually a very useful exercise because we found out that there were some gaps in some of the areas sometimes, so that meant that we had to make some changes to the system. but there was also highlighted areas where people hadn't actually done some of the training, so we were able to go back to them and say, this is actually how it's supposed to work, and you were supposed to follow this process rather than the process that they had followed. So that was a very useful experience for all of us. We ran it over approximately 2 weeks, so as the more engagement you get in there, the better. We then went on to do a full dress rehearsal. So we took a sample of 2 wards. We went to the intensive care ward and we went to a surgical ward. And what the idea of this was to make sure that you could transcribe the paper onto the electronic drug chart to make sure that all of those medicines are able to be prescribed, and can you find all those medicines? Are they working as expected? And this was actually a very useful exercise because we did have some teething issues in ITU, and we learnt a few lessons before we went to the go live. So I think this was mainly run by the pharmacy team, so it's actually a very useful exercise. We ran a lot of knowledge transfers to support the other teams. So we had what we call the informatics team, such as the red shirts and the change team, and they weren't always familiar with the pharmacy processes and the workflow. So we ran knowledge transfer sessions to try and engage as many people as possible, and so that people had an understanding of what everybody's different sections were, because these aren't always necessarily clinically trained individuals. We also had, so staffing, as always in the NHS, you can never have enough staff. So our motto was the more the merrier. So if people came on to do extra shifts and help us with the transcribing, they were more than welcome. And as we rolled out, I think we realised to start off, we probably didn't have enough to start, but you never do. And then towards the end, as we were getting more familiar, we were doing better and better. In terms of the rotas at the Royal London, we were very organised. We had our rotas all done and ready for the go live period. However, we found that the team wanted to have that we were asked to do shifts during the night, and we didn't find that was particularly useful because we weren't doing very much in the evening. We were actually needed during the day, so we managed to change that going forward in the other sites, because the bulk of the work is really during the day, and that means that you can not only provide support to each other, but support to your pharmacy colleagues and your other MDT colleagues if you're there during the day, and if needed, we were available on call if needed overnight. So in terms of bank shifts, we made sure that we had people coming in to support us in terms of the transcribing team, so that we made sure that people were getting the time back that they were if they were supporting us, if they were outside of the EPMA team, or payment if that's what they required. We also then had to very clearly map out the ward plans. So for example, we had to know if patients were going from to make sure we were going from non-COVID areas to COVID areas, so making sure that we were going from green areas to red areas depending on the site. So sometimes you had to change around the ward order that you might have to do. You had to also be mindful of the staff that you've got, as some people, due to occupational health restrictions, cannot go into those red areas. We also had to make sure that people had their PPE and were fit tested. When we were at the Royal London 50, was an extra ITU bed base, and so what we did is we had all the drug charts photocopied and then taken through to the transcribing team so that they could transcribe them, and then a pharmacist on the ward was making sure that that was still an up-to-date copy when they were going back into the COVID ward, to avoid everybody having to go into the COVID positive area. We just had one person who was the runner, a dedicated runner. So in terms of developing a checklist, we did develop a checklist. We probably did this a little bit late. We did it after we rolled out at the Royal London from all of our lessons learned, but it was very useful because it was simple things like making sure that everybody's smart cards were working, making sure that there were temporary access cards for people that didn't have smart cards. So I think that's a really useful thing to develop if you get the opportunity. Next slide, please. So as we've said before, it was we did roll out during COVID, so most of our training was actually through MS Teams or electronics. So all of our pharmacy training modules were online. There were pharmacy specific modules which we asked everybody to cover, but then there were also modules which weren't specific to pharmacy, but we did encourage others to cover as well. So they were some of the nursing administration tasks, Some of them were intensive care modules, because as you know, when you're on the ward, you will get asked questions by everybody. So the dietitians, the nurses, doctors, you need to be able to support all of your colleagues, so that we found that that was quite useful. The good thing about the electronic and e-learning packages was that you can visit it as many times as you like, as long as you complete the test at the end. We also facilitated what we called bite-sized training videos. So everything that was covered in the e-learning packages were also covered on bite-sized training videos. So we did a 1-hour session every day the week before go live for every site. So we repeated that 4 times. We then delivered that via MS Teams and then uploaded that onto the shared folder so you could access it and whenever you like, so a bit of bedtime viewing. We also produced a frequently asked questions document, which I think we had some very positive feedback, which was useful to people that hadn't possibly seen the system before. So, for example, learning lessons from the Royal London for people at Whipps Cross and Newham. We also developed some excellent, along with the change team, can't take credit for them, for some excellent QRGs and user guides, which were available for which were distributed and left via computers and left on the workstations on wheels for people to be able to read and take away if they wanted to, but they were also available through Millennium, through PowerChart, so they were really useful for the teams. Next slide, please. Okay, so a dedicated slide to transcribing. So just to say with transcribing, I think one of the most important things that you can do is to make sure that you've got your drug charts ready. So make sure that you know it's chart 1 of 1, chart 2 of 2. Do you have your allergies completed? Are your weights on there? Do you know if the patient is also on a variable rate intravenous insulin infusion? Do you have a separate chart for epidurals, etc.? So make sure that they're in a tidy position as they can. So the pharmacy team worked very hard before rollout to make sure that those drug charts were in a good working order. We actually had we were lucky we had a dedicated transcribing team, which didn't include the core EPMA pharmacy team, because we just wouldn't have been able to do our job as well as helping with the transcribing. So we had a dedicated team of doctors and pharmacists who were doing the transcribing. So we found that the best way to do it was to get the doctors to actually do the transcribing and then for the pharmacists to check, because that's very much what comes naturally to us, and we found that that was the best way to work. We also had nurses just helping and facilitating that as well in terms of looking at the medicines administration side of things. So that was some of our nursing informatics officers as well. We developed a transcribing induction before the rollout, which was, we ran 2 sessions of an hour each before each rollout. We encouraged everybody to join those sessions so they knew exactly what to expect and what was expected of them. We also ran a daily briefing session to look at any lessons learned or anything that we needed to adapt going forward. So usually we would have a briefing in the morning around about 9 o'clock and then another one in the afternoon, usually at 1 o'clock. And then we did adapt things and make changes according to the feedback that we got from the transcribing team. We also recommended that every one of our transcribers was familiar with our transcribing checklist. So there were lots of do's and don'ts on there and things like where to find care plans. So do you know that there's an anaphylaxis care plan available within the system? There was a list of all of those included in the checklist. And we also had a specialist section for looking at things like PN. We didn't want everyone prescribing PN, so we just put a placeholder on there and a notification to make sure that the PN team reviewed it when they were next on their ward round. Next slide, please. So I think one of the luckiest things that we had a chance finding whereby one of our pharmacists realised that before the hospital had electronic prescribing had been turned on, because we were in a hybrid sort of mode at previous to EPMA, we were still using PowerChart to record some documentation and to record blood results. We were able to actually document some drug histories. So what we did before the rollout at Whipps Cross, Newham and SBH is we updated all of the patients' drug histories, whereby they were all on the system, and then all the transcribers had to do was then reconcile those 2 inpatient orders, which made the transcribing a lot quicker, a lot slicker, and a lot safer. So, and it also provided the pharmacy team with the opportunity to have a play with the system before we went live and become familiar with what was inside the catalogue as well. So that was a really positive step for us. Next slide, please. Of course, everything doesn't run as smoothly as you'd hope, and we did encounter issues. So we had a lot of issues with the discharge workflow. People weren't following the correct processes. They were often jumping from A to Z without going sequentially ABC. They were doing things like going from jumping lots of steps, which made it very difficult to unpick what they had done and then be able to solve those problems. So I can't emphasize enough how important it is to follow the correct workflows, and then you will find that it's actually a lot easier to find out if there is an issue and be able to support people as much as possible. So I think we've ironed out some of those problems now, but it did take quite a long time. A lot of that had to do with some of the training, people not undertaking the training in the way that they should have. We also found that at the beginning there was a real lack of understanding of the pharmacy workflows. So certainly at the Royal London, all of the questions would come to the core EPMA pharmacy team. However, as we rolled out, the change team became more confident, the red shirts became more confident with our workflows, and they were then able to answer some of those questions. So I think the more you can embed that training and knowledge in your other team and undertake knowledge transfers, that will definitely help you during the rollout period, I think. So scanning is, of course, a new way of working. We're still having teething issues with this, but I think that we're certainly making some headway with it. So I would certainly recommend having a simulation suite available if possible. We did manage to set one up at Newham, but we had to restrict the numbers due to COVID, so we couldn't have too many people in the room at a time, but people were able to come in and have a play and actually have a go with the scanners before we went live, which was useful. We also had issues with printers. Of course, always have to have problems with printers. So the thing with SBH was that SBH used lots of satellite pharmacies, and unfortunately the system was set up whereby all of the printing goes down to a main dispensary. So we then had to add in extra printers all over the hospital. Luckily, we managed to get this sorted out before we went live, so that didn't cause too much of an issue. So make sure you know about all of your satellite pharmacies and you know exactly how your dispensaries work. So I think that was something a lesson that we learnt the hard way. We also kept an internal log of all of the issues that we had during the rollout. So we had the major issues whereby we had to make sure that we dealt with them immediately, and where we had Cerner support, we often delegated Cerner to do that because they're quicker and able to make those builds faster changes than us as part of the team. And then we had an Excel spreadsheet for what we would call the nice to haves and things that we're still working on at the moment. But I think it's really good to keep a record of everything that you've done from a governance point of view as well. Next slide, please. So I think it's definitely worth mentioning that intensive care was definitely our biggest challenge. We have got 44 beds, ITU beds at the Royal London alone, 10 ITUs across the trusts, which includes 130 ITU beds. So they have, as you all know, they will have very complex workflows and very complex medications. So we definitely recommend having an ITU trained staff member within your transcribing team on the day that you transcribe ITU. So I would recommend having the doctor and the pharmacist, because we had, luckily, when we rolled it across the other sites, we had those members with us, and I think that made it a lot easier than it did at the Royal London. At the Royal London, we worked until almost midnight trying to get those drug charts onto the electronic system, and it was a very, very tough day, but we did pull through. But it was definitely a big challenge. I would recommend involving all of the key stakeholders at any workshops that you have, so that you don't get any surprises when you get to that site. And every place has their own nuances and different ways of working, so we've sometimes learned that a little bit late. I would say to do it in the middle of the week, so that you don't have, so you have enough time. If you have something you need to catch up towards the end, it gives you a little bit of leeway. And any changes that go into the EPMA care plan now need network level agreement. Next slide, please. So my recommendations would be to make sure that you have a doctor to support whilst you're transcribing, so that you can ask any clinical questions. We also had pharmacy support when we went through to the other sites. So our lead clinical pharmacist and deputy chief was checking all the drug charts that had been electronically transcribed, because you can imagine how daunting that would be for a pharmacist that's coming in for a whole ward that's been flipped from paper to electronic and now has to be verified, so having that clinical support really made them feel a bit more comfortable with that system. So providing that support made life a lot easier for those pharmacists. Unfortunately, we didn't do it at the Royal London, but we learnt to do it for Whipscross and going forwards. That made people feel a lot more confident. We also recommended support for the first ward round to increase nursing confidence as well, so that people don't get frightened from the off. We cascaded information via bulletins, and we've had very positive feedback through that. So that's a good way to help people to learn new processes. We have I would consider more ward-based teaching. We were able to support people on the wards. However, it was difficult during COVID to get any of that done, to get it done to the extent that we'd like to. So that was something that we did rely mostly on MS Teams, but it's something that I would recommend going forward. It's nice to actually do some things face to face. We did have drop-in sessions as well, so people were able to drop in and see us and visit us and have at the training suite that we set up at the Newham. So that was something that I'd definitely recommend going forward. We did use MS Teams really as our main form of communication, which allowed us to know what was going on the wards, and it was a great way of keeping in touch with people. So I think it's definitely invaluable. Next slide, please. So I think it's really important just to focus for a few minutes on our reasons for success. I think we had an amazing team. We worked really well together. We worked across lots of different teams. So we had clinical teams, non-clinical teams, and everybody communicated really well together. I think that our preparation is absolutely key. So if you fail to prepare, you certainly prepare to fail. So I think we had some excellent steps in that way. We had to be flexible and adaptable. So with COVID, we sometimes had to change ward orders. We sometimes had sickness in the team, so we had to be as flexible as possible. Everybody, it goes without saying, worked extremely hard, and we had excellent communication within our team. And so we managed to successfully roll out at Barts Health by the end of December 2021. So that was 4 sites in 4 months. And we're very pleased to say that we've hopefully improved patient journey and improved patient outcomes at Barts Health. Thank you very much. If you have any questions, that's all from me.
That's great, Amrit. Thank you for presenting. It was a really informative slideshow showing your implementation at Barts Health. So there's been a few questions that have come through to the chat. So one of the first ones is about, I don't know if you clarified, which EPMA system was implemented at Barts? Which provider did you go with?
So we use Cerner Millennium.
Okay. And then one of the questions, because you were implementing during a pandemic, I know you had mentioned things about fit testing and PPE, but what were the other challenges that implementation during the pandemic brought along?
I think there's lots of challenges. Obviously, we had to look at staffing. We had to be careful about going into red zones. We had to be very careful with our staff itself. So there were people that were under occupational health that couldn't go into certain areas. So whether it's a transcribing team or the core EPMA team, you also have to look at people's well-being, and that's a very big important thing at Barts Health as well, to look at the well-being of our staff. So I think that's something that we had to think about. So we didn't want to push people into areas that they weren't happy with, and we also wanted to support people as much as possible. So luckily we were able to do that because we were a very cohesive team.
And that's great. And how many members of the team did you actually have?
So the members of the team, they changed quite a bit throughout the pandemic. But to be honest, we had roughly 4 permanent people, and then we got bigger as we went along, and there was like some people left and some people joined. So, but yeah, at the moment we're running it on myself and my colleague Rena Lal, who's a deputy informatics, and we have a locum helping us.
That's great. I've got just a couple more questions that were in the chat. So one of them was your e-learning package. What software did you use, or who did you go with?
What
software was used for the e-learning package?
Oh gosh, I'll have to check with the I'll have to check that with the team. I'm not sure of the name of the software, but it was all the internal trust one. I'm not sure what the name is, but I can get back to you on that one.
Okay, and what's your plans for deploying? The last question has just come through from Jane. Is do you have plans on deploying to outpatients or to day case, or has it already been deployed out?
No, so we're scoping day cases at the moment, so we're looking at that, and then we will hopefully have a business case for looking at outpatients as well. So we had a discussion about that this morning, so that's something that we will be working on.
Okay, that's great. Thank you, Amrit. And that will move me swiftly on to our next presentation. So we have Chadney and Cumbria and Joe Grayson from the Whittington Health, who are going to present about EPMA implementation in outpatients and the emergency department. So I'll leave you to take it away.
That's great. Thanks a lot, Steph. So afternoon, everyone. Hope everyone's doing well. So myself and Chadney, today we're going to be talking to you about our experience of rolling out electronic prescribing in our outpatient area, as well as the ED department. So we've both been working at the Whittington Health, Chadney for a fair bit longer than me, but I rejoined about 2 years ago. And just to give some context, this kind of was starting, this rollout started at pretty much at the start of COVID in 2020. Next slide, please. So just because I'm quite bad with keeping the dates in line through this presentation, on the right hand side there's kind of a log of what we were doing month by month, if anybody's interested in kind of the timelines of how that's going. So just to set the scene a little bit, we kind of deployed our outpatients through about sort of 6 to 9 months really, which I'll talk you through. At Whittington, we use a system called JAC, also known as WellSky or CMM recently. We're on a bit of an older version, which is 2014, but we've had that always in our inpatient areas since I think it was 2012, 2013 it was implemented, but we've had some resistance in pushing it into outpatients and ED. So yeah, just set the scene a bit more as well. We were at the time a team of 2.5 full-time equivalents. We had some outpatient prescribing activity. Around about 30% of the outpatient prescriptions that came down to pharmacy were electronic before rolling this out. And a lot of those people that were prescribing there were kind of very engaged consultants that were using it on the inpatient side on the wards, but were also running outpatient clinics. So we had a little bit of activity going, but it definitely wasn't the majority. And we hadn't had any electronic prescribing in A&E before this kind of project went underway. Next slide. So as a trust, it's always been in the plan and the pharmacy strategy to roll out to A&E as well as outpatient clinics. I think there's just been some long-standing issues around adopting the change. A lot of the time we found that consultants or people that had been prescribing in outpatients on paper for a long time were really the people that didn't want to change, and it was quite difficult to get them engaged historically. We know that ED also wasn't really too keen to uptake electronic prescribing, and I feel that a lot of that is down to the perceived flexibility that a lot of ED areas think that they have with paper. I think that EPMA gets a bad rap in ED, and it feels like it doesn't always fit, but we know that it definitely works. We've seen it in other trusts. So there was a big sort of change management piece around that, which Chadney will talk to you a little bit more about in terms of ED, but that was kind of some of the challenges that we've just had historically within the trust. Next slide, please. So I feel like I'll be preaching to the choir a little bit, so I won't go into the benefits of EPMA, but there's lots of your standard stuff, you know, like legibility, you know, compliance to formulary and all those kind of things. But just because this started to take place right at the start of COVID, COVID basically created a whole new set of benefits that we then started to push out to build momentum behind the change management piece in the trust. So if you think right at the start when at COVID, when we really didn't know how much of effect it was going to have, there was lots of concerns around sort of touch points for different things. So if you think about a prescription that's written by a doctor, that's then handed to the patient brings the paper prescription down to pharmacy, that goes to somebody who's booking it in, that goes to the pharmacist to screen, dispenser and out. So there was a lot of touch points that were happening around there. And electronic prescribing, because the prescriptions could be printed directly in pharmacy outpatients, it kind of took off pretty much half of that process. So that was a big additional benefit that we kind of started to use. Obviously, the massive one was facilitating prescribing from home. So our outpatient clinics, a lot of people were isolating or went off sick, but they were still able to work. But the limiting factor was the fact that we were on paper. So by enabling electronic prescribing, people could still use it at home and they could help out their colleagues. And actually, I still think to this day, a lot of outpatient clinics can still run from home. You know, consultant from their homes calling patients and organising prescriptions and diagnosis from there. So that's definitely a big sell point for EPMA in outpatients. And the final bit is that there was a big reduction in waiting times for patients and generally the amount of people that were just hanging around waiting for prescriptions in pharmacy. So if you think if you're conducting a remote clinic, you call the patient, you then prescribe something. We always said at the end of our training for our outpatient consultants, if you've prescribed something on the system, let the patient know and ask the patient to call pharmacy. So before the patient even stepped in to the hospital, they knew that their prescription was ready to collect. So we'll show you kind of a patient sort of audit that we did in terms of their experience, and that went up quite a lot. But as well, it was just quite nice to reduce the footfall in the outpatient waiting area. Next slide, please. So this is what our paper prescriptions look like before the rollout, just to sort of give you a taste. I'm sure they're pretty similar across most of the trusts. So I'll just show you as well what our electronic prescribing process looks like on for outpatients. Thank you. So effectively, the prescriber logs on. They're asked to sort out the allergy status for the patient. So it's pretty straightforward. Next slide. One thing that we've never had on paper is the ability to see the history of what's been prescribed for patients. And this is saying, yep. And you can search for the drug, pretty straightforward. Next slide. Thank you. Really straightforward interface. You've got just the dose and frequency and whether the GP needs to continue it or not. So, yep. And we can add notes as well. And they actually print out on the physical outpatient prescription that comes in pharmacy. So as you can see, that's a pretty straightforward process. It's not difficult. It wasn't difficult for our prescribers to pick up. You know, it's really straightforward and it kind of nicely takes you through that workflow. So on the left-hand side, we've got the paper prescription, and on the right-hand side, we had what the electronic version looked like. Thank you. Cool. So in terms of, so that kind of sets the scene of where we were at and what we were hoping to do and kind of the sell points that we had when we were going to the outpatient areas trying to get people on board. So this is kind of the actions that took place once we'd started pushing out around April. So in all honesty, because of COVID, there was very limited planning. It was just, look, this needs to happen and we're going to have to go. So in a nice way, there was people that for the most part of 7 years that would hide in and didn't want to speak to us as an EPMA team at all because they didn't want us nagging them about getting on the system. Then all of a sudden we're queuing up outside the door, really trying to get on our training sessions. The other thing that we felt as well is I think that a lot of the people like the clinical directors or people in charge of the service provision, they knew that if people were trained on the system, they could also facilitate help from home. So that was a big driver behind getting a lot of the clinicians trained. So we had to deliver training. Obviously, social distancing kind of impacted us. We normally have a training room that we can fit about 10 people in, but that went down to 5 with social distancing. So we utilized virtual training, Teams, WebEx, you know, the lot when they first started coming out. We tried to engage with the specialties directly. So a lot of areas will have things like audit days or, you know, the team meetings. So we trained the whole of dermatology, all of the consultants and regs in one day when I think they had an audit day there, which was really nice. So good use of time from our end and just got a whole service up and running, which was nice. We definitely encourage anybody who is thinking about rolling out to do this as well. But we linked in with our outpatient pharmacy and said, could you just jot down on a spreadsheet or even if it's on a piece of paper who was prescribing on the blue prescriptions, so we could figure out which clinics or if there was any problem prescribers that hadn't moved over, and then we'd use that as a bit of a driver to where we would go training next, and that seemed to work really well. I definitely recommend this point for anybody who's rolling out or considering rolling out to outpatients as well. at the end of our training session, we said to all of the prescribers, look, here's our bleep number or our office number. When you do the first prescription, just give us a call. If you get stuck anywhere, or even if you just want somebody to walk through with you the first one, like we tried to make a big point of always being there, because we found that if somebody doesn't get the first prescription right, or they run into some trouble straight away and we're not there at hand, that's the moment that everybody reverts back. People, they find one little problem and it's the first reason that they look for to go back to papers. So if you're there on the phone, or if you're there with them, we found that that was a really good way of keeping people on, because once you've done one, especially on the outpatient prescribing side, it's so straightforward. A lot of them aren't too dissimilar. So yeah, we think that works very well. We had a major benefit, as we said, that the system is particularly easy to use, and yeah, we provided lots of one-to-one training if it was needed by particular areas. Next slide, please. So we advertised our training over lots of platforms. We went to lots of service leads to try and get the call out. And after a couple of weeks of training, and the uptake was really good, we then got in line with our chief pharmacist. We got an agreement to just stop supplying the paper outpatient prescriptions. Now, that felt quite scary to start with, but it was really the driving force between getting the final sort of 10–15% of people that hadn't been trained on the system. So as soon as we sent out communications about not sending this up to the clinics anymore, pharmacy refused to supply any, then we saw like another sort of peak in our training where the last group of people came on. But although it's a bit of a difficult decision, we definitely recommend doing that, you know, once you've got a fair amount of people on the system, because it's that final push to kind of say we're phasing out the old way of working. Next slide, please. So this is just kind of some data to show what happened. So after about 2–3 months of starting the kind of rollout, or COVID starting really, we'd trained about 80 consultants that then were active and using the system. So you can see, as I mentioned at the start, in February, the kind of red line is our amount of prescriptions that were done electronically, and the blue line is what was on paper, and we were getting this audit from outpatient pharmacy. But before we started, we were at 30% electronic, and then by May we'd gone up to 60%. So yeah, that's kind of where we're at. Obviously we had outpatients, which A&E, which were still using the majority of paper prescriptions, so that's kind of why we didn't hit the 80–90% marker just yet. Next slide, please. So that pretty much wrapped up the outpatient prescribing section. So what we tried to do is we undertook a survey with the outpatient consultants that we sent out like a Google form to ask them questions to see how they were getting on, because we were quite aware that we'd very quickly pushed out this training to the trust, and we didn't want people, particularly consultants, to feel like we just trained them and kind of left them in the lurch, and there was no then feedback communication to how we were doing. So we sent that out, and we sort of were waiting for feedback for the best part of 2 weeks. We then collated the information, and it was quite good. It was pretty positive. So 74% of the information we got back was positive or neutral. Based on the negative comments or the feedback that we got, we then sent round a sort of "you said, we did" newsletter, and it was just really simple things. It just felt like some people just weren't sure where to be signposted as to how to get a password reset, or when they should call outpatients for clinical information as to when they should call EPMA for, you know, EPMA issues. So it was just kind of dividing the lines there. We got some really good feedback from there. I think the prescribers appreciated us getting in touch with them again. And I guess the final bit to mention as well, if anybody's thinking about trying to get a case together to roll out to outpatients in particular, is that there was a cost saving to the trust in terms of reduction in the controlled stationery. I think you might be quite surprised about how much the outpatient prescriptions can cost and how much we churn them out. I mean, I definitely was. Next slide, please. Cool.
Thanks, Joe. I can take over.
Nice one, thanks.
So over the period of our outpatient clinics.
Your volume's not coming.
Hello. Testing. Can you hear me? No?
Yeah, I think you're good, Chadney.
Yeah? I think the
Challenge
team's
to
saying they
be-
can't hear me.
It's a bit delayed. It's delayed.
No, we
Okay,
can-
team
we
is
can
saying
hear
it's a
you.
bit delayed. Okay. Sorry. So over the period of outpatient clinics going electronic, the service that was in an outpatient pharmacy changed significantly. So patients were now told at the end of their outpatient clinic appointment to call the pharmacy to arrange for collection or delivery. So it wasn't they were kind of just turning up to the pharmacy department. And this reduced waiting time significantly, because if there were any queries regarding stock issues, they could be resolved prior to the patient attending the hospital. And also for shielding and vulnerable patients, they had their medications delivered to them via volunteers, which is really, really useful. We did have a drive-through or pickup service if that was needed. And we had couriers available for urgent medications where patients lived far away or there were no volunteers available. We also had some tracked postage for any non-urgent medications where patients lived far away, which was really useful as well. Next slide, please. Thank you. So the outpatient pharmacy undertook a patient survey. They telephoned over 100 patients, and over 90% of those found that the service was either very good or good, which means that the trust meets its target for patient experience, which is great. The majority of patients stated that they felt very happy, and this is especially because they didn't have to come into hospital, because there was lots of anxiety about coming in during the pandemic, and especially for those vulnerable patients as well. This electronic service meant the patients didn't have to come in and everything was delivered to them, so that was great. Next slide, please. So the success of rolling out electronic prescribing to our outpatient clinics gained traction with prescribers in A&E. So then initial meetings took place with A&E in May to discuss prescribing outpatient prescriptions electronically. There had been resistance over the past kind of 7 years, but we did manage to win them over. And kind of just to clarify, it was patients who presenting into A&E and then they're going to be sent home most likely on the same day. So those prescriptions, instead of writing those on paper, they were now electronic. Next slide, please. So by around June, July, we had trained over 200 prescribers and nurses. There were staff from other healthcare settings who were redeployed as well. In the past, we rarely come across fraudulent prescriptions, but I have come across some whilst I've worked here. But with electronic prescribing in place, it was virtually impossible for patients to forward prescriptions. And that was a big factor that we used to get the consultants on board from A&E. Next slide, please. As you all know, no project runs without having a few problems. So in terms of pre-go live, some problems that we had, one of them was regarding social distancing and providing training. So Joe touched on this earlier. Usually we'd use a room to train 10 staff members at any one time, and we had to reduce this to 5 staff members, which meant increasing the number of training sessions and looking for alternative spaces to train. But as you can imagine, everyone who provides training in the trust was also looking for bigger spaces to train. So that was definitely a challenge. But to overcome it, we used lots of electronic training via Teams and WebEx and things like that. There was a lack of resources in the team. As Joe mentioned, the team consisted of myself, him, and one other 0.5 whole-time equivalent. So it was a really small team back then. And to overcome this, what we did do, though, is train the A&E pharmacist so she could start training the A&E staff through her day. And that was really, really helpful for us. In terms of post-go live, we didn't train staff to enter the medication indication and bleep number, which is something that normally would be included in a paper prescription. So outpatients pharmacy found this quite challenging, and the information wasn't available readily. And so to overcome this, we then started training staff members that they need to include this information on their prescriptions. Another problem that we encountered was out of hours training, so for any kind of agency or locum staff, because the team only worked Monday to Friday 9 to 5:30, and also creating usernames and passwords was difficult. But to overcome this, we made some e-learning modules, which we now use for the majority of our training. Next slide, please. So here are our results over 6 months of rolling out electronic prescribing to both outpatients and A&E. The red line is the JAK electronic prescriptions, and we can see there's been a steep rise after we implemented in A&E, so just around July, and that went all the way up to 77%. And the blue line is the paper prescriptions, which goes down to 23%. Next slide, please. We also gathered data to determine the reduction in prescriptions needing clinical interventions from pharmacy, because we had lots of prescriptions which might not be legible, or the controlled drug prescriptions don't have the requirements that are needed to process them. So the green line here shows the overall percentage of clinical interventions, and that had reduced from 5.6% to 3.4%. We also had to take into account that there was less outpatient activity than usual, as some staff had been redeployed. Therefore, this would have meant there were less prescriptions and therefore less clinical interventions. Next slide, please. So we had some feedback from our A&E staff. One of them said that, "I can't believe we didn't do this earlier. It's been the best thing we've ever done." Another one had said, this has meant less running back and forth between A&E and pharmacy as the prescriptions are sent electronically. And another said that this has allowed me to work from home, which is brilliant, as I feel that I help my colleagues on site from a distance. So it's really positive comments back, which was great to hear. Next slide, please. In terms of post go live, we then spent September and October trying to switch any clinics which were still using paper over to electronic. And this included kind of off-site clinics, smaller clinics which are run by off-site consultants, for example, ophthalmology. And there were a final few clinics which are generally nurse-led. So we tried to get those on board. Next slide, please. This targeted approach has led us to 96% of prescriptions being prescribed electronically. We believe the final 4% are prescribers who present to Whittington once every 10 weeks or so for half a day to run their clinic. So once in a while now, I still get some blue prescriptions coming through to me. And as soon as I get those prescriptions, I go and speak to those prescribers immediately, because if you don't catch them straight away, then you may never catch them because they'll be gone. Next slide, please. In terms of lessons learned, e-learning will significantly help any rollout effort, particularly considering social distancing issues in training rooms and for off-site workers as well. We would advise to create an endpoint for an old process. So the fact that we had a specific date that we were no longer going to be supplying paper prescriptions, even though it was a difficult decision, it was the main reason that prescribers were forced to kind of book onto training. And then also to ensure to obtain baseline data for the current process. So because we rolled out so quickly, we had limited baseline data available. Next slide, please. The other lessons learned is we would say to contact other trusts for advice and lessons learned, because that's invaluable experience. And also to use the culture change of COVID-19 to enhance the digital agenda of the trust. You know, obviously COVID is 2 years on, but if you can still use it to move things digital, that'd be great. And what I'll do now is pass over to Joe for the last slide. Thank you.
Thanks, Channy. So yeah, just a few just last points in terms of lessons learned. So like we said, we'd definitely recommend doing a like-for-like mapping with your current process. As Channy mentioned, we, in our rush to roll out, missed some pretty basic things like, you know, the bleep numbers not being on the prescriptions, the electronic ones. So we had to go back and retrain people, get the word out, say, look, add a note to put in these bleep numbers. Same thing with the indication of the drugs. So that's one thing to keep an eye out for. Another thing, when we were kind of targeting the last clinics, which is a practice that we obviously don't like, is pharmacy, but unfortunately exists. A lot of areas we had, not a lot actually, 2 or 3 in particular areas, they had developed a practice of like the specialist nurses writing out the prescriptions and then getting the doctors to sign it, which obviously is something that shouldn't be happening anyway, but is a double challenge when you're trying to roll out EPMA there, because you're then not just trying to train a doctor, you're trying to basically you're trying to unweave a whole list of problems. So if you can try and identify those areas first and just make sure you've got a fair bit of time to, you know, organize the provisions and make sure that they're aware of the change. Yeah, and like we said before, definitely I'd recommend a support for the initial prescription, because a lot of people will just look for the first reason to go back to paper. But if you can be there for that, it kind of makes sure that they remain on the system and isn't less of a headache later down the line. So I think that's it.
Cool. Okay. Thanks, Joe. Thanks, Chadney. So I'm going to ask you a couple of questions, but thank you for your presentation. Really informative. So a couple of questions that have come through is, you had mentioned during the outpatient prescription process about the controlled stationery. Do you know exactly how much was saved, and were the costs offset by the delivery? And because you'd also mentioned delivery from outpatient, so was it cost neutral or was an actual saving?
So I guess there's two parts to the question. One is that it roughly worked out, I think, to be something like £6 grand a year, but it's a recurring sort of thing. I think we actually need to do, I'm in touch with the SIP team at the moment, because I think we're going to try and take a look at that. But the other thing as well that we haven't looked into is FP10s. Now, we didn't switch those over, as we will be soon, but if anybody's doing that, they're an even bigger cost that you can save on. The other part of that is that we didn't offset it directly, or we haven't looked at offsetting it directly with the delivery from our outpatient pharmacy, because they're almost like a separate entity to us, but we supply the outpatient prescriptions. But what we did look at is trying to figure out, you know, how much the paper that it is printed on costs to offset between those things, but it's minimal. But yeah, we definitely say just do a little scoping exercise and take a look, because that can often be a nice little way into, you know, getting the pharmacy to move over as well if there's a cost saving in there.
Okay, so I have two more questions which are going to be really quick, and then I have to move on. So what do we do about controlled drugs and controlled drug prescriptions with the wet signatures? How do you combat that if it's from a distance?
Yeah, unfortunately, there's no way around that legally. We looked into it for a fair bit, but if it's a controlled drug, it needs from hospital, it needs to have a wet signature. Now, I know that there's some work being done by suppliers, because the EPS service allows, I think it's called a secure signature, which allows that to happen in community pharmacies. There's been a big push to adopt that, you know, in hospitals, because of the challenges that COVID have presented. I think it's been trialled in somewhere, but I don't really know any more than that. So I think from a legal perspective, it has to be printed and signed at the moment.
Yes, that's fine. And then my last question is, have you noticed with the practice, has most people reverted back with that, as the pandemic has gone along? Do you think people have reverted back to paper charts, especially within the ED department?
So we can say that that's certainly not happened, and a lot of that is because we don't supply any prescriptions now. So basically the whole thing's run out. We keep a fair stash just in case we have like downtime or something that we can push out to the wards, but we've remained pretty consistent. The only places we haven't really completely got around to is very occasionally there's some clinics that are run by other sites, so we link quite tightly with Royal Free, and sometimes their prescribers come over once a month, and they're very difficult to capture for training. But as Channy said, we're at about 96-97% at the moment, so we've been pretty consistent with that.
Okay, that's great. Thank you for answering the questions. There's quite a few questions in the chat that still haven't been answered, so we'll send them out to the speakers, and the answers will be put on the NHS Futures website within a week's time. Thank you. Thank you. I just want to say thank you again to all our speakers. So Ampreet, Chadney and Joe for talking about implementation during a pandemic, whether that's the first implementation across 4 hospital sites, as Amrit at Anan at Barts Health, or implementing EPMA within an outpatient setting and within your emergency department. So next steps, I'm just going to talk about an event that we're organising, which is happening next month, which is called Transforming Lives with Digital Medicine. It's an all-day virtual event happening on the 27th of April next month, and it's for anybody who's involved in implementing, optimising ePrescribing or digital medicine systems. As we know, digital transformation is at the heart of the recovery plan, which we can see by the presentations we've had today. And this event is going to be a combination of speakers and workshops, bringing the digital medicines network back together, and so we can share and help teams share their learning and learn from others and how to support them with their implementation, optimization and adoption. The registration link is on here, and the presentation will be available on the NHS Futures website. And please feel free to share with your networks, and it's for anybody involved in e-prescribing or digital medicine systems. And we will have keynote speakers from Ansley and from Tony Avery, as well as teams from Somerset, Lancashire, and Nottingham, and teams in London as well presenting. So please feel free to share. And on that note, I just want to thank everyone for attending today's webinar. The links will go up after this session. And if anybody has any ideas for any future topics or has any feedback or wants to volunteer to present at future sessions, please email Sarah Black, and her email is on the screen. And please remember to hashtag our masterclass, use the hashtag ePrescribing Masterclass, and join our network. Thank you, everybody, and we'll see you next month on 9th of April. See you, everyone. And again, please remember to register and come and join us on the 27th of April.